All right, well, Jordan, thanks so much for the invitation to present here at the second annual AI lecture series. I think this is a really great program, and yeah, it's really great to see how it's all come together over the last couple of years. My name is Paul Yee. I'm the director of the University of Maryland Medical Intelligence Imaging Center, along with Dr. Parekh, who's our technical director. We co-lead a research group as well as a center. And today I'll be talking to you about potential pitfalls in MSK AI research and applications. So something a little bit more on the clinical side, and I am a practicing MSK radiologist. Following our disclosures, none of these are really relevant to what we're talking about, but they do support some of the work we're doing. So our objective today is to review potential pitfalls of AI research and applications in MSK imaging. And it'll be pretty short. We'll go over potential pitfalls of AI in MSK imaging and talk about considerations for the practicing radiologist. So potential pitfalls of AI in MSK imaging. So before talking about AI, whether training or deploying or testing, we have to talk about data sets because this really forms the basis of all that we do. And when it comes to dataset curation, we've seen things like the chest X-ray 14 dataset, which was released by the NIH, which have supposedly 112,000 frontal chest X-rays, which is a huge boon for anyone trying to do AI. More data is better, generally speaking. But one of the questions is, how hard is it to tell if there's a frontal or not frontal chest X-ray? I'm assuming for most people or everyone in this audience as radiology residents, you know the difference between frontal and not frontal. And this should seem like an easy enough thing to do bookkeeping for. But when we actually look at the data set, there are quite a few non-frontal chest X-rays, a lot of laterals here. There's an abdominal X-ray, and there's actually a couple hip and pelvis X-rays for good measure. So this is all to say that metadata and natural language processing, which are automated ways to extract this information, is not 100% accurate. And so this is one pitfall of these data sets, that it might not be what you expect, even for something as simple as radiographic view. And this has also been shown on the disease level. So if we use natural language processing to try to look at radiology reports, extract things like disease labels, we might be tempted to say this is perfect, the computer did it. But in this review of the MURA dataset, which is a dataset of upper extremity radiographs, when actually looking at these labels of diseases, there's a range of sensitivity and specificities as low as 60% in the case of degenerative disease. So it's important to recognize that these data sets are not perfect and in fact may be far from it. This is a separate review that we did of the MURA and LYRA data sets, which are upper extremity and lower extremity radiograph data sets respectively. And we tried to see how clinically useful are these. And what we found was quite a range of suboptimal images. So in this case, these were duplicate hip images with inverted pixels from a single patient that was labeled as abnormal. Now, what you can see here is that the pixels are off. You can imagine if you train an algorithm to look for a normal X-ray set of pixel intensities, if we test it on this, everything's gonna be flip-flopped. Similarly, we have duplicate images. Dr. Parekh mentioned some things about data leakage. This is a problem because if we assume that there are, let's say, 4 hip images and they all represent a unique patient or image, well, we would be mistaken here and we might have exaggerated results. And then similarly, we've got a whole range of other quality and clinical issues. We've got a montage of multiple views in one image. That's very different from getting a single view in one image. We've got fluoroscopy images, including this so-called radiograph data set. And we have varying levels of over and under exposure. And importantly, these are saved in a PNG format, which precludes windowing and leveling. So we irrevocably lose information at the extremes of the pixel intensities. So this is all to say that data sets are a pitfall, and hopefully this is encouragement to all the radiologists in the crowd. We play a big role in doing the quality control, making sure that our data sets are clinically relevant. So we talked about data sets, let's talk about models. So the second is lack of robustness to clinical variations, and I'll expand on that momentarily. So many of you are probably aware of bone age, whether clinically, you do this in the PEDS reading room, or in the AI world. This was actually the RSNA's first AI challenge back in 2017. And a team from Canada called 16-Bit actually won this challenge to develop an AI algorithm that had a mean absolute difference of about 4 months compared to radiologists. And this is really outstanding because it's just near expert level and this is unlikely to be clinically significant. But one question I want to pose to you is, does AI have common sense? This is an app that actually was recently shut down by 16-Bit. This was publicly available. It was pretty slick. You could upload an image. You could actually use your smartphone, take a photo of an X-ray. It's available now, but you got to pay for it. But back when this was available, we tested it out. We put a hand x-ray in, we get a bone age. But if you put in a chest x-ray, you also get a bone age prediction. If you put in photos of flowers, you get a bone age prediction. And then you put in a photo of a then radiology resident, you get a bone age of 1 year and 5 months. And so the point of this is to say is that although this bone age algorithm does exceedingly well on bone age prediction, it's with the caveat that it gets a bone age x-ray. If you put any other image in it, the algorithm will fail to recognize like, hey, this isn't a bone age x-ray, but it's actually a photo. So this is where also I think AI can be seen almost like savants. They're very good at a singular task, but you ask for anything else, at least in its current stage, doesn't do so well. Maybe something a little bit more clinically relevant is this so-called stress testing when we look at clinical variations in images. I'm sure as all of you have seen by now, even if you're an R1, images do not always come in a standardized way on your pack. Sometimes they're rotated, and then you have to manually rotate them yourselves. Sometimes the contrast and brightness are suboptimally presented, so you have to manually do that. Well, the problem, as I mentioned before, is that these images are often saved as JPEG files or PNG files. And what that does is it locks the image pixels in place. And even if you do something like a histogram equalization, there is data that has been lost. And so what we did is we did a stress test of that 16-bit algorithm, and we evaluated images in different ranges of variation of appearance. So in this case, rotations. And what we found is when you rotated an image 180 degrees or 270 degrees, you had a huge jump up in the mean absolute difference and a bigger range. Basically saying that, hey, just because it did well on the normal images, if we just take the images from packs and maybe some of them are rotated, we might not get the performance that we expected. So this is all to say, AI often can lack robustness to clinical variations in the real world because these data sets, they tend to be curated specifically for machine learning, but the real world is often different. All right, so that was a very clinical kind of pitfall. Let's get into something slightly more technical. I promise this is still pretty intuitive, and that's called shortcut learning. So the idea with AI, just as with a resident, we hope that they can look at a radiograph and tell you abnormal versus normal. But what can happen is that there can be a confounding feature in the middle that the AI or maybe a really smart or clever resident can pick up on and say, huh, well, I think this is normal because of X. And one of these potential confounding factors is a laterality marker. So you've seen these throughout medical imaging, particularly in radiographs, as well as technologist initials. So usually for quality control. So what we did is we trained 3 separate CNN classifiers on the Mura dataset of upper extremity radiographs for normal versus abnormal. One with the normal or regular images, second with a black box covering these labels, and the third on these labels themselves. And what we found was that on the original images, we had an area under the curve of about 0.84, so pretty decent. When we took the radiograph labels themselves, so literally we took the R and the L and the initials, and we labeled them normal, abnormal, we had an AUC of 0.64, which isn't outstanding, but that's saying that there's some signal in here that the AI can just look at the label and tell you with greater than chance accuracy, there is an abnormality. And what that means is there's a confounding feature in that label. There's something in the data set where these labels are associated with normal or abnormal. And then when we actually put a black box over the masks, the AUC jumped up to 0.86. And then when we look at these heat maps that I'm sure some other presenters have talked about, at what the AI is looking at. So in this case, this was the original data set. Well, lo and behold, for like 90% of these images, they were looking at these radiograph laterality labels. And then when we look at the labels themselves, well, there are features here that are correlated with the normal or abnormal label. But notice what happens when we put a black box around this label. Well, the attention starts to focus towards the bones, as we might expect. And one thing to note is laterality markers are ubiquitous. So this is an open problem in our field that these things are kind of embedded into our images. And so to prevent shortcut learning, well, that's something that remains to be solved. But I think starting out with identifying the problem is the first step. So moving on to explainability. So as I mentioned, heat maps are used to visualize kind of roughly where is the AI focusing on or what pixels are important for decision making. And so this is seen throughout the literature. This is from a paper published in Radiology back in 2020. But the question is, can we trust them? The idea being that these should hopefully increase our confidence in the AI's predictions and even potentially provide localization of the abnormality. And so we did a systematic review or evaluation rather of saliency map techniques for MSK radiograph localization, as well as some other trustworthiness evaluations. And we tried to evaluate, if we have a heat map from a CNN classifier, how well does this localize with bounding boxes placed by radiologists? And what we found was that compared to human radiologists, all of the heat maps did worse. And so the idea here is that saliency maps, although they can be useful in certain situations, they're still a far cry from being something super trustworthy as far as localization of disease goes. Now, one thing I want to present that was just published in Radiology AI was this new type of deep learning algorithm called a vision transformer. And we won't go into the nitty gritty, but basically what's to say is that these heat maps on the CNNs, which are often not that helpful because it's like this looks like someone took a bucket of paint and threw it on the radiograph. These vision transformers seem to have attention, and literally attention, that's the technical component of these vision transformers, on the abnormality regions more closely. So we can see here in this diaphyseal fracture of the humerus. So that's something, if you're curious, we just published this, really interesting stuff. And we're just scratching the surface of vision transformers. And the last thing I'll talk about here as a pitfall is bias. So, there's bias demonstrated in healthcare, and those things unfortunately can perpetuate into AI. This is a paper showing that when you have sex imbalance in chest X-ray data sets, you get bias classifiers against the underrepresented sex. And so what Hugh Harvey, who's a radiologist working in the space, said was, well, we can tell often on a chest X-ray if this is a male or female based on the presence of breasts. I would be more concerned if the same was found on head CT or ankle fractures. And we evaluated just that, something where you can't readily tell if there's a male or female. So knee osteoarthritis. And essentially what we found was that when you have imbalanced data sets, you do have bias against the underrepresented group. And then just circling back to the Bone Age app, we just published this paper in Radiology where we evaluated for bias in this app. And recall that this is the winner of the Kaggle competition. This is really the gold standard for what a Bone Age app should be. And the idea was that these algorithm was trained on images from Stanford and Children's Hospital, Colorado. And then what we did is we tested it on a diverse data set from Children's Hospital, LA. And what we found was that there were biases with clinically significant errors higher in females, children at the oldest and youngest ranges of the age and sexual maturity spectrum, as well as non-white children. And a little bit more concerning too is when we try to figure out, well, why is that? When we look at race, there really is no discernible pattern of either overestimating, so above the mean, or underestimating below the mean line. So even debugging these algorithms can be tough. And one underlying mechanism, this is a paper that got a lot of press by a friend of mine and some of the other speakers, Judy Gichoya, where they show that AI can actually predict race on the basis of these images. And so, these deep learning models are black boxes. There's incredible strength, but there's also incredible potential pitfalls in identifying features that we don't want it to identify. So we'll close with some considerations for the practicing radiologists. I think we've seen a lot of pitfalls. So it's important, know the reality and use it accordingly. Related to that, trust but verify. We have to embrace these technologies, I think, as something that can really move the needle, but also, be skeptical. Make sure that we're putting it through its paces and being smart about it. I think also learning basic AI concepts. You don't have to be a computer scientist, but if you want to engage with AI, either clinically or in research or in quality or any of the above, I think that it really helps to learn some basic concepts. So we have some great radiographics articles geared towards radiologists for this type of thing. And one thing I come to realize is that AI is a lot harder to do than some of the computer science people said back in 2017. So, this is a cartoon by my friend Felipe Kitamura. X-axis time, y-axis my fear that AI replaced my job. Started out very high. When I trained my first deep learning model, I realized I'm pretty good. So with that, AI has tremendous potential to improve radiology. Pitfalls do abound, however, in every stage of AI development and deployment. And by being aware of and addressing these pitfalls, we'll be able to allow AI to reach its potential. And so all of this work, wouldn't have been possible without many, many amazing collaborators over the year, and these are just a few of them. That leads me to today to our team here at the University of Maryland Medical Intelligence Imaging Center. And just one other shout out to the Radiology AI podcast, which I host for the RSNA. If you want to learn more, hear more about some of the contemporary topics, tune into Spotify, Apple, or wherever you get your podcast. And please stay in touch. My last name is 2 letters. My first name is pretty common. So if you ever need to look me up, it should be pretty easy. And with that, appreciate your time.
That's really fantastic. Thank you so much, Dr. Yi. Well, I'm going to take the time for my own first question while the other questions roll in. So related to algorithm bias and these tools that make it to market, so who should be held responsible for evaluating if and when these biases come up? Or I guess to clarify that more, should it be on the onus of the radiologist, or should it be on the industry, or should there be a third party that that's evaluating all this data independently?
Yeah, to be honest, I struggle with that because I don't know the answer. I think on some level, it's easy to say like, hey, FDA. The FDA is our, at least in the US, it's going to be our government agency that should be vetting the safety of these technologies or softwares. But I think it's, to give the FDA some slack, it's a hard thing. I mean, AI, so many of these pitfalls, so many of these things like bias and fairness issues, they're not things that are readily obvious. And so the FDA is really trying to build a ship build a plane as they're flying. So I think it's got to be a group effort. If I were to throw my hat in the ring, I think that FDA plays a role by establishing standards and being like the first gatekeepers. But I think that if we look at analogous technologies in radiology, like radiation and nuclear medicine quality and safety, it still falls on the department to do their daily checks, make sure that the machines are calibrated appropriately, make sure that the, whatever things in the machine are, so I'm clearly not a physicist, right? But I think there should be multiple levels of responsibility, of care and evaluation. I think ultimately that's going to be the way to prevent this kind of Swiss cheese kind of effect where things just fall through the cracks. Yeah, and I think that allows for different levels of granularity as well as assessment.
No, that makes a lot of sense. Thank you. So we do have an additional question that came in for Dr. Parekh. So Vishwa, I know that I think I sent these to you in the chat as well, but there was a question, how will Federated Server help a center that doesn't necessarily have the modality choices that the server has information on? And this is in reference to the first topic, federated learning.
Right, yeah, can you hear me? Hey, okay. So these are really good questions. I'll answer both of these one by one. I think regarding the first question, which is, can we have both cross-modality as well as cross-domain learning together? The answer is yes. Our group is really active in this particular area where we have created setups where different clients could have different modalities as well as different tasks and different domains. And the federated server, not your vanilla server, like not something that comes out of the box, but with a bit of algorithmic innovation, we are able to work with these particular problems really well. And I think that regarding the second question, it's slightly related to the same area where if you've just set up your federated server, and if the new client does not have the modality of choice, but if it has something else to contribute, it could definitely join the consortium and essentially empower the server to learn information about that modality as well. But if it's joining when the server is already trained for a bit and it already has knowledge, but not specifically about that modality, it brings us to a different field of research called lifelong learning, where the idea is that we sort of combine both federated learning and lifelong learning together in this case. But the idea with lifelong learning is that if you don't have a particular knowledge, you want to integrate that in a way so that you don't forget what you already know. So in this case, the federated server would try to integrate the knowledge that this new client has about this new modality into its framework without having to forget what it already knows, but essentially integrating it in a way so that all of the tasks that it already knew would be able to perform on that modality's inclusion as well. So very interesting problems. I would say very problems of really active research right now. And we are trying to find answers to these questions.
That's a great and thorough answer. Thank you so much, Vishwa. So Dr. Yi, we have one additional question here. Well, I have a couple questions rolling in. But so in regard to the randomization and the types of bias that can exist within the data sets, would you imagine that potentially randomizing which data set to choose could address some of this bias?
To an extent. I mean, I think what's behind that question is sort of like, well, are we going to have a data set that can be balanced that would hopefully be achieved through randomization? But I think the problem is that these data sets are often unbalanced to begin with. So even if you randomize, it's going to be reflective of whatever the underlying prevalences were. So if your population happened to be 60% male, 40% female, if you randomize it, you're probably still going to have 60-40, or you may have some of the splits being 50-50, but you're going to necessarily have others being more imbalanced. Now, that being said, you can do things like intentional oversampling or undersampling to achieve a balance. But I think bias and fairness is a challenging thing to address because it's not just like a univariate kind of relationship, right? We talk about like multivariate, analysis, because you could say male and female is just the only factor that matters, but it's not. There's going to be different factors that are associated with the male and female, like disease prevalence or severity. We look at race. There have been racial biases demonstrated in a lot of these algorithms. We look at things like BMI. We look at things like, there's just so many factors. So I guess it's, the randomization can help, certainly. But I think that because these algorithms are black boxes, it's hard to really debug them. So that might sound like a little bit of a cop-out, but I think that rather than being a cop-out, it's more of an acknowledgement on my part that this is exceedingly complex. And I think there are factors beyond just the technical or kind of statistical. And that really, would be my plea to the residents that you all have a real place, even if you're not going to be involved in, let's say, AI coding or, hardcore AI research. The clinical insights about the data sets, about the disease processes, about the potential confounding features, that's going to be so critical. So, so the TLDR is randomization can help, but it's just one piece of a very complex puzzle.
Yeah, absolutely. All right, well, we have one additional question here, and then I think we will close this session and leave a little bit of time for just course feedback. So I believe this one is also for Dr. Parekh. So again, in regards to federated learning, would it be possible to integrate two modalities or multiple modalities to solve a diagnostic problem using an AI algorithm?
Yes, I think if I'm understanding this question correctly, given that you have different modalities being contributed from different clients, your model would be able to train across these modalities. But would it actually work when you have only one of these modalities or say a subset of these modalities? Which again is a really good question. And it again, I'd say all of these questions, it again boils down to the algorithmic approach that we use. Yes, this is actually doable. We have done that before. It's again a model or a framework that you would use directly out of the box would not be able to do that. You'll have to modify your architecture and your AI algorithm in a way so that it learns the contribution of each of these modalities as individual modalities, as well as using these modalities as a set together. So yeah, this is doable. It's just that it would require a different algorithmic approach. But yes, we have seen that this is possible to do.
Fantastic. All right. Well, I know there's still a couple of questions that are in the chat. I will answer these personally, and if there are any that would be good for a tutorial or a tweet discussion, we can hopefully get to those later. I am also going to plug the RSNA AI podcast. I'm very happy that Dr. Yu brought that up. That's been one of my primary ways of getting exposed to some of these special topics and fundamentals of AI. So I highly recommend it to anyone who's looking for some further resources. Beyond that, I greatly appreciate you both joining us today. 2 fantastic lectures, great Q&A. And we will look forward to seeing everyone tomorrow for day 4 for AI nuclear medicine and economics of AI.